Hello everyone, my name is Masaru Sasaki from Japan. I am very happy to be able to speak to you today. I am a dentist. I work at a general dental clinic and I am also an oral pathologist and a site pathologist. Today I'll talk about oral cytology, especially about oral liquid-based cytology for early detection of oral cancer. In Japan, the number of deaths from oral cancer and pharynx cancer increased threefold in the last 3 decades. This is an inconvenient truth. Last year, an impressive event happened in Japan. A famous popular singer announced on her blog that she had advanced tongue cancer. When she was aware of a small ulcer on her tongue, she consulted a physician and a general dentist. But for about 6 months, they were unable to diagnose her tongue cancer. When she visited the cancer specialist, her cancer had already advanced to stage 4 with lymph node metastasis. She lived in the central area of Tokyo. Unfortunately, oral cancer is often not detected in early stages, even in central Tokyo, where the healthcare environment should be the most enriched in Japan. As you know, clinical courses of advanced oral cancer is not good. I graduated dental school in 1986 and I was trained in the Department of Oral Surgery at the Tokyo University Hospital. At that time, a lot of advanced oral cancer patients visit the hospital. But even now, almost half of oral cancer patients visit cancer specialists in advanced stages in Japan and maybe the rest of the world. This slide shows the 5-year survival rate of Japanese tongue cancer by stages. In stage 4, it is about 50%, but in stage 1, it is about 95%, and in stage 2, it is about 80%. Moreover, in the early stages, dysfunction after surgery is mild, and its costs for medical care are lower. Early detection will greatly affect a patient's chance. What is the effective way to early detection of oral cancer? Patients with such mucosal lesion shown in this slide sometimes visit our general dental clinic, but it is possible that early-stage oral cancers are hidden. Moreover, general dentists may notice mucosal lesions during treatment for tooth decay, root canal treatment, and regular maintenance of periodontal disease. So, even when the patient is unaware, actually, only this one case is oral cancer in early stage. In my opinion, it is very difficult to diagnose these lesions only by visual inspection and palpation. So, we dentists, a general dentist, need a new device for early detection. So, new device. For the cervical cancer, cytology is used widely for early detection. This picture is the father of gynecological cytology, Dr. George Papanicolaou. Oral cancer, the same squamous cell carcinoma as cervical cancer, account for about 80 to 90%, but oral cytology is not common. A conventional oral cytology is called brush test, started in 1990s in US. But conventional oral cytology need many skills and time for training to make fine microscopic specimens for general dentists. In my opinion, it's very difficult to take reliable smear specimen for a general dentist. Moreover, as you know, during the process of conventional method, many collected cells are discarded. Liquid-based cytology (LBC) im- improved this one, effectively utilize collected cells, and almost all collected cells are examined. Generally, the amount of squamous epithelial cells collected from oral mucosa is considerably smaller than that of the cervix. The reason is that the oral mucosa is constantly falling off due to the mechanical forces of hoods, toothbrushes, and things like that. So, LBC has an advantage, especially in oral cytology. About the LBC system, SurePass and SimPrep made by global maker are very common. SurePass by BD used a density gradient quantification system, and SimPrep by Hologic used a filter system. LBC Prep by Japanese domestic maker used basically a density gradient quantification system. This is a specimen of oral LBC processed by SimPrep for our patient. In this way, general dentists can make fine microscopic specimen. This paper is a study comparing a ratio of inadequate specimens and sensitivity and specificity between the conventional method and LBC in oral cytology. The results show that LBC method has fewer inadequate specimens, moreover higher sensitivity and specificity. The percentage is 12.4% in conventional method and 8.8% in LBC. In a study, the definition of adequate specimens is determined by collecting basal, parabasal, and intermediate cells. I'd like to point out the higher percentage of inadequate specimens than gynecological cytology. In gynecological cytology, the definition of adequate specimens is determined by the number of collected squamous epithelial cells. But in oral cytology, it is determined by the depth of the layer in which cells were collected. This is largely due to the difference between the biological nature of cervical cancer and that of oral cancer. In oral squamous cell carcinoma, well-differentiated cells are often found in surface layer, but early invasion may be found in deep cell layer. Actually, the accuracy of cytological diagnosis of oral squamous cell carcinoma greatly depends on the sampling depth. This is a very, very important point. Therefore, swab as sampling tools are not suitable for LBC. Previously, we have used side brushes or interdental brushes, but in my personal view, at present, the Osrex brush developed by the Lobe company in Netherlands is most suitable for oral exfoliative cytology. It is made of the same materials as the cervix brush, and the shape of the tip is designed to collect cells in the deep cell layer in the oral mucosa. In summary, these are the advantages of oral liquid-based cytology. 1. Much simpler techniques for general dentists. 2. Fewer inadequate specimens. And 3. A higher standard of specimens. For early detection of oral cancer, the role of general dentists is very important. Oral cancer screening devices for general dentists need to be simple technique. Oral LBC don't need complex technique, and every general dentist can perform this examination without a hard training. And for cytopathologists, standardized fine specimens are needed for a correct diagnosis. Therefore, I think that oral LBC is a useful examination for early detection of oral cancer. Concerning the cytologic grading system of oral X-rated cytology, in 2015, Japanese Society of Clinical Cytology (JSCC) established the first cytologic grading system in Japan. The Japanese grading system has five categories: nil, low SIL, high SIL, SEC, and INF. In our general dental clinic, we performed oral LBC for oral cancer screening since 2013. Among 99 examined cases, two cases were diagnosed cytologically as SCC class 5 and also diagnosed histologically as SCC. And one case was cytologically diagnosed as erosive class 3 in a clinic, and then he was diagnosed histologically as SCC in the consulted Tohoku University Hospital. This is the first case performed oral liquid-based cytology in a clinic. Case 1, 80 years old male. This case was obviously diagnosed clinically tongue cancer. 50 by 45 mm size ulcerative lesion with bleeding and induration were found on the right side of his tongue. Oral liquid-based cytology showed that basal, parabasal, and intermediate atypical cells. These cells showed high NC ratio and nuclear hyperchromasia. A few superficial atypical cells shows abnormally configured keratotic cells with orange color cytoplasm. In high-power fields, a light green colored atypical deep layer cell showed irregular nuclear membrane and dense cytoplasms, so this case was diagnosed as squamous cell carcinoma SCC class 5. And as consulted Tokyo University Hospital, this case was diagnosed histologically as squamous cell carcinoma well differentiated. Next case, we could diagnose cytologically as early stage cancer, stage 1. 70 years old male. The clinical diagnosis was soft palate ulcer, non-specific. 10 by 8 mm size small ulcerative lesion with slight bleeding were found. Induration was unclear. The clinical diagnosis was soft palate non-specific ulcer. However, an oral LBC, basal, parabasal, and intermediate atypical cells showed high NC ratio and nuclear hyperchromasia. Thin light green colored atypical deep layer cell showed irregular nuclear membrane and dense cytoplasm. So this case was diagnosed as squamous cell carcinoma SCC class 5. This patient was referred to the Tokyo University Hospital, was diagnosed as squamous cell carcinoma also histologically. Next case was cytologically diagnosed as low SIL class 3 in a clinic and were diagnosed histologically as SCC in the consulted Tokyo University Hospital. Case 3, 70 years old male. Clinical diagnosis was tongue cancer, 20 by 15 mm size ulcerative lesion with bleeding and induration was found. In oral LBC, superficial or intermediate cell shows nuclear hyperchromasia. The cell shows abnormally configured keratosis with orange color cytoplasm. Few uh, single orange-colored atypical cells show irregular nuclear membrane and dense cytoplasm. This case was diagnosed as Lossil class 3. This patient was referred to the Tokyo University Hospital and performed the histological examination, and he was diagnosed as squamous cell carcinoma. We could diagnose this patient as early stage 2. In a clinic, we usually refer to cancer specialists and patients diagnosed as low cell, high cell, and SCC cytologically. Next case was suspected gingival cancer clinically, but he was cytologically diagnosed as NIRM. Case 4, 70 years old male, clinical diagnosis was gingival cancer, 80 by 15 millimeter size, deep ulcerative lesion with induration was found on gingiva under his full denture. In oral LVC, many superficial keratinized mature epithelial cells show low NC ratio and nuclear neutrophil predominant inflammatory cell could be seen in the necrotic background. Orange-colored keratinized superficial cell is and the light green-colored intermediate cell show low NC ratio. So this case was diagnosed as NIRM class 2. In this case, after full denture conditioning treatment, his lesion got better soon. Finally, I will comment concerning pitfall and limitation of oral liquid-based cytology. The cytological diagnosis of oral squamous cell carcinoma greatly depends on the sampling depth. Therefore, it is difficult to diagnose early invasive squamous cell carcinoma with thick keratotic surface layer. For example, such white lesion with thick keratotic lesion, oral LBC is not suitable. So we should perform incisional biopsy. This is the summary. I believe oral liquid-based cytology is the most useful devices for the screening of oral cancer, especially ulcerative or erosive mucosal region. If oral liquid-based cytology become more common for general dentists, we can save a lot of lives of oral cancer patients. Thank you.